hi, I'm Dr. Luke Kornakia, and this is my son, Michael Kornakia. And this is the first of a series of podcasts that are designed to discuss not only the problems we're facing in healthcare, but also potential solutions and trying to understand why those problems exist. And we have here today as a guest, our first guest is Katrina Reese, who, hi, good morning, and and welcome, Katrina.
Thank you.
So we're starting this discussion to talk more about the some of the issues that you face in healthcare, because you've been working in the healthcare field for quite some time, and then had a medical problem yourself that you had to work with and grapple with, and finally get resolution with by treatment. Can you tell us a little bit about what you've done in the medical field?
Sure. I was going to I was in college for a psychology degree, and I had to just start working. Started working as an administrative assistant in a group practice, and then quickly became the billing manager. Um, I worked there for several years, and then I moved to durable medical equipment where I was helping out in an administrative capacity, a marketing capacity, and then I was doing appeals for them. So I kind of hopped around to various companies in that field until I got to hospital setting in New York City. I worked in um, on, I'll just say, the Upper East Side in medical equipment in the hospital, and then was working in New Jersey in a different hospital before I moved into a project management role for a company that is hired by property insurance companies. But during my um, during my time there, I did sustain an injury. I was in a car accident, and so that was a workers' comp case, and it's been a journey.
So that's a
I'll just say.
that was a work-related motor vehicle accident,
Correct.
all right? And so you sustained that a while back, and then were faced
Mhm.
with the onset of pain after the injury. Is that correct?
Yes, and I'm not married. I don't have anyone to kind of fall back on, so I had to keep working to pay my bills despite being in pain. So I'm lucky that I was able to do that, but it was very challenging, and it's not the regular case, I feel, for a lot of people who are experiencing those kinds of issues.
So when you faced this problem, you were working with your private insurance, but also now with a new form of insurance particular to this injury, a workers' comp insurance program that's statewide, New York State, that would cover all bills related to that particular injury in such a way that the private commercial insurance does not. Is that right?
Yes, because of my work experience, I already knew, oh, I can't go to my regular doctors. I can't go through my private insurance. It'll probably cause me issues later down the line. I've seen that happen where someone has a workers' comp injury, they don't realize that they can't go to their private insurance because it's hard to understand all of the nuances of how claims are processed and how benefits are handled by health insurance, especially if you don't
Saying
have
with 12
experience.
years of experience in healthcare, then you're actually a medical billing expert working for a medical practice. So even with all of that background, it was still hard for you to negotiate the payment process to get this treatment required.
Yes, because for workers' comp, everything needs authorization and it has to be through their doctors.
Um,
They have their own set of medical treatment guidelines and everything has to be in a certain way, but it takes a long time and it's very frustrating. I had already known from working with patients on the side of being for a provider. Oh, these are the cases that are very frustrating and hard, and these are the people that are just having they're having a hard time. And I didn't really understand why until it started happening to me. like, oh, this is terrible. This is, and I had a leg up with just having knowledge.
Right.
Um,
Right. So at this point, you're in pain, you're post-injury, you're trying to work, you're finding it difficult to work because of pain.
yes,
And now you're faced with the issue of trying to get coverage for the medical care needed to treat the injury.
yes.
And you're finding that with all of your experience and background, a difficult road to navigate just to get care.
Mhm. I don't think that I would have been able to do it if I hadn't been, oh, my cat has decided to join the podcast. My emotional support cat, Chicken. I don't think that I would have been able to handle it if I hadn't already done work on myself in terms of mental health. Chicken, come on. I had already gone to therapy for 10 years. So dealing with the anxiety and, stress of it's it's expensive to get injured, especially in New York City.
So,
I actually I got a lot of debt just from trying to get to and from physical therapy. And I'm still dealing with it.
so it kind of doesn't make sense from either perspective, your perspective or from the state's workers' comp perspective, because I mean their goal is to get you treated and back to work, right? And so it seems to me the longer it takes to do that, more expensive it is for the state also to make this happen.
Yes.
So where's
But I was trying to save them some money, and I mean I didn't know what to expect, and I'm not the kind of person that's like, well, I'm just gonna wait and kind of depend on somebody else. I had to pay my own bills, so my employer is very flexible with me. I was able to make my own hours and work around all the appointments. Um, but it was tough. It was really hard. I work with people all around the United States. So, time zones, I could shift things, but I also had to travel a lot. Basically, for my job, I go to houses after there's been floods and fires and natural disasters. So I'm helping people who are going through a traumatic situation handle something, which is dealing with insurance, a different kind of insurance, but they're all kind of very similar.
yeah, it
They're
is.
very similar.
So you must deal with people who are going through these kinds of problems in their own way,
Mhm.
with their own issues after catastrophic damage, property, and injury as well, right?
Yes.
So you see this over
And
and over again. The same thing you're going through, you've seen other people go through as well. But would you say that the workers' comp system was equivalent to the insurance programs that you help deliver, or do you think
no, it's way more mysterious, I would say is the word. That's a nice word.
right?
How
Um,
has it been mysterious? I'm curious. What have you dealt with that's kind of made it hard to see past? Because that's a very I don't know. Mysterious to me. I don't. It seems like you can't see anything that's going on behind the scenes. It's very like
well, yeah,
yeah.
that's I think the thing. It's like, okay, well, if you're saying that it has to be under these certain medical treatment guidelines, but not every patient is an individual case.
So from what I'm like, from my perspective, it's basically separated into a bunch of different systems. What I'm understanding about the healthcare system is that they try to make it as broken up as possible so that the people that are working under this case don't fully like see the big picture, so that it's not biased in any way. And I kind of understand that, but
well, I don't know. I agree with you, but I'm not sure if it's intentionally done.
Mhm.
I mean, you have to recognize that a lot of workers' comp was done on paper until just about 10 years ago. And so you'd walk into a workers' comp office and there would be dozens and dozens of desks, and each one would have hundreds of paper files with manila envelopes and be going through, and that person would know exactly where that chart was. Oh, that's on this pile and it's halfway down. They pull it out and they say, that's the and really now they've moved to records and electronic submission for claims, and a lot of the process of authorization is online. I think they're making an effort to create this environment So we faced this issue together in submitting authorizations, and I submitted the authorizations the best my office could, and still it took some time to get approval even after I met you. And went through multiple submissions, but in all candor, can we try to fathom why that's actually happening? I mean, if they're making efforts to create the software systems, and they're not all connected yet, but it takes a lot of work to make everything really connected and really flow, because it's not just data, it's all these processes have to be connected too. So
I mean, I kind of wonder, like, at what point does it become anyone's responsibility if someone's care is split up over all these different things, and it's really just down to numbers and codes and what does the computer
that's
say?
a really good point.
Yes,
That's a really good
the
point.
human connection. Where's the human connection? And that's what I was going to get down to a minute ago. I was going to ask you about something a little different, just so that we could kind of get introduced a little more. You weren't allowed to pursue medical treatment using commercial insurance. Rather, you had to use the insurance that you were talking about earlier, which is workers' comp.
Right.
Thank
Which
you.
is very frustrating. It's like, well, I'm paying for this, but it's just how it's supposed to go.
Is your experience, have you worked with private insurance versus the workers' comp prior to this? Has it been a different experience? How have you experienced that? What was that difference there?
I mean, I've had multiple private insurance plans over the last, I'll say, 20 years. And each one was, it's different. Like each insurance company, they have their own kind of pros and cons, I guess I could say. Like it also depends on the plan, and I was lucky to kind of get insurance after the pre-existing conditions issue was not something that was considered. Um, so the plans where I didn't have to get authorization from the insurance company before I could seek medical care, um, those were the best ones. But then the ones that I did need authorization, and then it's kind of this gatekeeping process of, I would like to get this, please, and someone deciding, well, no, we're not going to cover that, or your benefits don't cover that, or we would like for you to choose a less expensive option,
Yes.
which is not great.
Of course, it's not great. I think, yeah, it kind of circles back to what we were talking about prior.
I think the issue of gatekeeping is probably a really central issue. And it looks like if you look at Medicare, for example, straight Medicare, there is no gatekeeper. The physician is the gatekeeper, and there is a gatekeeper as a physician, and it's up to the surgeon to make the right decision, the right analysis, the right diagnosis, the right recommendation for surgery, the right differential diagnosis, and ultimately the right correct diagnosis. All and then perform the procedure or intervene in such a way that we successfully treat the problem. But the HMO programs of the late 60s, I guess, really initiated the idea of gatekeeping with health maintenance organizations, which most insurances now are either have their own HMO plans, or they impose the HMO concept of gatekeeping across all their insurance plans. So that seems to be a central process in most insurances, with rare exceptions. And so then the issue becomes, how do is this no fault process? Is this process of assigning responsibility, and then so in some way gatekeeping by correcting or second guessing the physician? Is this a necessary process? Is this something that must be done in order to maintain the sanctity of the healthcare system?
It's a complex issue because you have resources that go towards how do you decide what cases are more important and less important? And I think that's ultimately what it gets down to. You have to decide, is this case really urgent, and do we need to?
So
Yes.
you're saying that in order to preserve their financial stability, they have to make sure that appropriate surgeries are being done. That concept. But I think we're seeing that now in the news that there is more here to that. I mean, it seems to me that the shareholder and the share value is paramount in terms. It seems to be more of an issue of how do we maximize profit than it is an issue of how do we maintain integrity of the care system. And
Yeah.
so so now it becomes an issue of, okay, so it's your profit versus the patient's care. And so is that where ultimately this all lies? Is this all a matter of greed and maximizing profit at patient expense? And I don't know the answer to that question, but a lot seems to be coming out to suggest that's the case. I mean, after the tragedy of the homicide of the CEO of United Healthcare, we saw a lot of issues come up. We saw United Healthcare pull back on their denials, and then we saw BlackRock actually complain that they were pulling back on the denials because BlackRock was concerned about the value of their investments in United Healthcare.
Yes.
And so, but that's our system is kind of intrinsic that you may have shares in United Healthcare. It becomes an issue of where the patient lies in all of this, and where are the priorities in terms of quality care for the patient, and so you can make that statement, right? So what is it? Is it greed and preserving profit, or is it actually a process of maintaining the integrity of the financial health of the insurance companies?
I mean, it's so hard to tell, but it's kind of disturbing that it's easy to imagine that it could be nefarious things too. I mean, if you think about it, like if patients aren't healthy, then in a way the insurance company has the opportunity to make more money. So how do we get people to be healthy or motivated to not even need to involve themselves in uh, you know using their health insurance? But it's kind of like, well, how can we tell, because we're only able to analyze statistics of people who go to get care, but there's so much. I mean, I just think about the amount of people who do have issues and either don't seek care because they don't have the money to do it, or they get so frustrated about it and it's confusing and they are afraid of how much money that they're going to have to spend. Um,
Yeah, I
and
mean,
yeah,
you've navigated this program. You mentioned having some mental health support in the past and how that helped. So you had that,
Yep.
and a lot of people don't have that background. And then second, you mentioned having worked in the healthcare field, so you know how all this works, and from a provider's point of view, and you've seen all of that from both taking care of patients and helping getting bills paid in the doctor's office, but also for DMEs, which are two big expenses for any healthcare program. By the way, DMEs are durable medical equipment, and it separates the expense from something like gauze, which is used once and discarded. But durable medical equipment includes braces and wheelchairs.
Braces, machines, and wheelchairs,
Machines. Those are all durable things that last and
ambulatory
require
things.
care of a patient. Just to make that clear. So there's this issue which becomes kind of opaque, this greed versus financial integrity, and then you open up the issue that, well, BlackRock is representing United, California mostly funds, I think, but many Americans have investments in United Healthcare. So then, does that mean that everybody with investments in United Healthcare, having purchased stock or whatever they've done, to have some interest in the welfare of the company's financial performance? Do you think that they're all conflicted? Do you think that this is such a conflicted issue that a third of the patients out there are conflicted about whether or not United Healthcare is involved because they're investors in United Healthcare? So does this make this such a muddied area that we never get to a solution of this?
I mean, that's a good question. It's just hard to say. I mean, I guess I think of it like, if you have money in anything, then intrinsically want to kind of root for it. Like, well, like, how are you benefiting?
Right.
So it's kind of looking at what are the benefits, whether it's financial or not. Like, there's all sorts of different kinds of benefits for anything. I mean, you even the way that you vote, you want the person or the thing or the place that you choose to do well, because why wouldn't you?
That's clear. So the point is that I think is that there's always kind of as much transparency as could possibly exist, even in that situation. If this is all transparent, there would still be issues here which make it muddied or difficult to
Mhm.
fathom. And so then you say, well, at that point, who do you turn to keep things running the right way? And I think the answer has been one thing. What do you think? Who do we rely on? What does the system rely on to make sure that throughout all of this and throughout all of the you know financial issues that these companies have to manage as well? Um, who's responsible for making sure that patients get the care they need?
I mean, I would think that it would be the government. I mean, you're supposed to be representing the people, and the people need care,
Right.
and yet the people don't understand what that care means unless they have certain degrees. And yeah, I mean, it's just so much to understand, and people don't have the time or energy or money or patience or mental capacity to handle all of the information while also suffering or watching people they love suffer from the things that they do, which is there's so many horrible things, and it just keeps getting worse and worse.
Yeah.
And so it's kind of are we putting a band-aid over stuff by like focusing on health insurances more than like if you took health insurance out of it completely, then what would you do? I guess.
Right. That's right. That's absolutely right. And I guess the other issue that's happened in the last 100 years is that we've actually learned to treat and cure problems. I mean, 1920s, we didn't even have antibiotics, so treating basic problems was virtually impossible. It was reliant on use of salts and iodine, et cetera, to try to cure basic surgery. In fact, a lot of surgeries are being done without the use of gloves, for example, which we would consider ridiculous today. But so now we've moved to an era where more and more can be treated, and that's accelerating. So now with modern advancements, we're able to look at the molecular biology of cancer like never before, for example. So there'll be new medications, coming out regularly to the point where we'll be able to cure a lot more than we can cure now just in 10 years. So that's the whole process is accelerating. So I think that makes this whole problem more acute because we're kind of chasing our tail. In a sense, we've made all this advancement. We can treat all these things, improve longevity, quality of life. At the same time, the business model we're using to preserve, financial status and maximize profits is really, counterproductive to getting care to the person as rapidly as you can to solve the problem and let them move on with their lives.
And there's also the issue of the expense for medicines that are like cutting edge medicine
Yeah.
that can solve an issue. I mean, I have a loved one who has multiple sclerosis and has a marketplace plan and needs authorization for things, but was able to get approved for uh, infusion therapy that is every 6 months. So it's not a daily pill. It's not a, weekly or monthly injection. It's one day every 6 months. But each of those treatments costs $250,000. At least that's what the facility is billing, and they're getting paid a good chunk of it. So, but as a patient, you see that number and it's like, wow, this is expensive medicine. But why? Why is it so expensive? Is it the ingredients? Like, can you tell me more information as to how do you decide on how much to bill? And how does an insurance company decide how much to pay? Because it's all scheduled. They have to decide, they have to have contracts to agree on how much different medications are, and that's a touchy subject. I mean, I can think of like the EpiPen issue
Right.
several years ago, just because some guy, basically, I'll just say, was like, no, it's going to be more expensive. At least that's how I kind of understood it. And
Right. We're seeing that every day. We're seeing situations where there's sudden increases in the cost of medications, and people aren't able to get the medications they need to
they
live.
can't live like that.
And I know
Yeah.
there's a mother, I think out of the Midwest right now, suing insurance company because they denied asthma inhaler, which is a different inhaler than he normally used, but one prescribed by a doctor, and he died of respiratory attack and failure. And he was only, I think, in his 20s. And so I think a judge just allowed that lawsuit to go through so they can continue lawsuit against the insurance company in order to try to, the mother and father, to try to gain some level of justice. Because if he had his inhaler, the sense is that he would have survived or wouldn't have had that attack. So these are really life and death issues. And for you, it was how many years of waiting for the right treatment to occur until you
They get surgery 3.5.
3.5 years. So if you think about, we have a life expectancy of 85 years, 89,
Mhm.
7 years. So 3.5, well, let's say 4 years out of it, that's 5% or 4% of our life that you spent doing
Yeah.
that.
And during a time of my life where if I had wanted to have a child, it's kind of like the last kind of bit of time that I really would have, should have been working on that if I wanted to.
Right.
I mean,
So,
luckily I haven't.
so I actually had a injury this weekend, to be honest with you, where I hurt like pulled the back muscle, and I was in so much pain, and I had to go over to the ER. I wanted to go over to the ER, but my dad said, "No, we're not going to go to the ER right now, because it's going to go away, and the ER isn't going to do anything for you, and it's just going to end up being a huge bill."
And I could prescribe medication.
Yes, we also we had a conversation about it, and we talked about it, and I agreed the ER might not be the best decision because the bills that came out of the ER were going to be substantial, and I just decided, okay, I'll wait this out. And the pain that so luckily for me, the pain subsided. I cannot imagine the people that have to go through that amount of pain every single day without getting any kind of help.
Right.
And the amount of it,
And having to rely on pain medicine.
yes, exactly. It was crippling. I couldn't even drive my car without like without feeling an incredible amount of pain, and just turning the wheel was impossible for me. And I also want to say one other thing, which is if all authorization, we wrote this up last week, if all companies, all of these insurance companies approved every single one of these things, then the company would fail. And so the issue becomes, how do you balance that without greed coming in? And I think that we should talk about that as well.
So the issue then becomes the question is, would these companies fail? I think it should be a question first, Mike.
Yes.
Because the question is, if they approved every request for treatment,
That's what I was asking.
right? And then do we know for a fact they would all fail? I guess you can say Medicare has always had problems. It's funded by the government, and so so you can make an argument that there are issues about not having a gatekeeper in the Medicare program, and maybe that's an iteology to some of their shortfalls. But it's not completely clear to me that if they approved all of the requests, that they would be out of business. I mean, it seems to me that they're doing quite well financially, or at least they were until recent other political issues have come up, such as United Healthcare or Aetna. But let's play both sides of that. I mean, if in fact, what are your thoughts, Katrina? Do you think that these companies would go out of business if they didn't have gatekeepers?
I don't know. I mean, it's definitely a complicated question. Immediately I think about, I have a family member who has Lyme disease, and it's difficult for her to get the care that she needs and have it covered by insurance. So the insurance will deny authorization for all sorts of stuff, medications or treatments that are requested by the doctor, and they deny the authorization based on the idea of like, well, there's not enough medical documentation. There's not enough studies that show that this would be justified. So there just hasn't been enough research to show that this would be an appropriate response to whatever your diagnosis is. Also, by the way, about that diagnosis, we don't like that you are diagnosing with that. And so now we're going to question you, doctor who treats Lyme disease, because doing you're making decisions based off of what? If we don't have the information and you're making these decisions, then you must be doing something wrong. So we're going to take your license from you. We're going to complain and get your license taken away. This is a common issue.
Also, a very big issue, by the way. Sorry, I don't mean to.
No, you're right.
Oh, no, it's fine.
Because the doctor's legitimacy is being questioned over the sake of a corporation or the person that's in charge of the corporation, and that's a problem. You have somebody who has 10 years of medical or 10 years of training on top of however many years that they have, and that must be very difficult and very hard to get through as a doctor to your patients to talk to them about, tell them about.
Yeah,
I'd like to hear your opinion.
Well, I think they clearly are. And so what gives them the authority to do that? And how do they gain that authority? So I guess one thing the insurance companies do is they hire nurses and doctors to evaluate cases. That's the peer review process. And so they'll say, this doctor is requesting an anterior cervical discectomy infusion for this particular patient, and the MRI report says this, and you agree. And now these doctors are being paid to evaluate the case. But obviously, if they approved every case, I think it can be implied that their position would be,
they wouldn't need it. Yeah.
Right. And so it would need them. And so they're there to deny cases to some extent. And that leaves, so now we have an employee of the company that's trying to save money, actually make judgments about whether or not the case should be done. So then the company goes like United Healthcare, and they acquire 90,000 physicians in this country, which is about a tenth of the entire physician workforce in the United States. So now you have another issue, which is you have the treating physicians actually employed by Optum, which is a subsidiary, I believe it's a subsidiary of United Healthcare. And as such, so now you have tied to the insurance company. And so there is this obfuscation of responsibilities. Is the doctor responsible to you, or is the doctor responsible to their employer? And that becomes a whole other issue. And then if every doctor is in fact an employee of companies, are they responsible for the company and the financial well-being and success of the company, or are they responsible for the care of the patient?
Yes.
Right? That becomes the issue.
That is a big issue. Yes.
So how would they respond to that? They would say, well, we're responsible for both. We're responsible for the success of the company, and we're responsible for, is it possible to do both? Is it possible to have employed physicians be responsible to the patient and responsible to the source of their income?
I mean, that's kind of seems, yeah, like circular reasoning almost. I had a doctor who was a part of a group, and I think Optum is the umbrella for United Healthcare. So the doctor was part of this multidisciplinary practice, I'm going to go see this primary care physician. They're going to recommend this specialist. I can go in the same complex, and, they all take different insurances. I just have to check, and I have the ultimate decision that I'm going to go to whatever doctor I want. And I mean, I had the experience of being in a waiting room and overhearing someone working in this office kind of reprimand a secretary for referring a patient to a different list, like their insurance provider list, rather than the providers in that practice, because they want to keep the patient in-house.
Right.
So that's a different kind of problem, like ethically.
I mean,
Because
it's a huge issue, right? The focus needs to be on the patient. The focus ultimately needs to be on the quality of care and the outcomes for the patient. And it seems to me that the system isn't doing that right now, in that you got to wait 3.5 years to get treatment, which then caused you to put a lot of life on hold, essentially.
Yeah.
So those things were done. So it
Like,
didn't.
is there, I'm sorry, I just had a thought. Like, is there anything in place where insurance companies are rewarded for the successful treatment of a patient?
This is a quick side note from the actual podcast. There are actually systems in place in Optum and United Healthcare, which are VBC contracts, that state that if patients stay healthy and avoid like hospitalizations that are very costly, Optum gets higher profit margins. So there are coming out with that stuff with Optum and United Healthcare, and Blue Cross Blue Shield has something called Blue Distinction Program.
Mike, if for example, workers' comp, which has, let's say, X dollars at the beginning of every year to treat all the workers' comp patients, right? You would think that if they could successfully take the patient, evaluate, properly diagnose, do the appropriate treatments per guidelines, get to a point where if those guidelines didn't work and pain persists beyond physical therapy or pain management, get to a point where analysis is completed and surgery is considered, and then surgery is considered as an option performed, and then the patient recovers, such as cervical discectomy success rates about 90%. So 9 out of 10 patients get better with the surgery, and then most go back to work within 6 weeks. And so the reality is, if you do that in sequence, the current recommendations are 3 to 6 months of conservative management. If you fail to improve sufficient to be able to move on with your life after that, or if there's weakness or progressive weakness, both of which indications for earlier surgery, then the recommendation is that you consider surgery at 6 months, and then if the surgery is pursued, typically the patient is back at work and doing what they normally do by 9 months. And you can shortcut that, but if there's no improvement at 3 months and the pain is still severe and there's no functioning, the recommendation is that's when acute disease becomes chronic. Acute pain becomes chronic pain by definition at 3 months. That's the point where you're strongly considering surgical intervention in order to minimize long-term sequelae. And so that didn't happen in your case. And so now we're looking at why, and we're saying, well, because there was this gatekeeper effect. And I guess they would defend themselves by saying, well, we didn't have the information we needed to properly define your case, and so we couldn't approve it. And so we had this, you're right, this very circular reasoning process, but the whole company would actually do better. Workers' comp, it's not a company. Workers' comp is a state fund. But it would actually do better if it treated you faster, because you'd be back at work and joining the workforce again, full time, full duty, and being able to live your life. And so New Jersey seems to look at things a little bit differently. What I've seen in New Jersey is that there are instead of the gatekeeper effect, there's more of a medically trained attendant who basically follows a specific patient through all the treatments, both conservative and then, if necessary, surgical, and is involved in every aspect of it. They're called case managers. And I think New York has case managers too, but in New Jersey, the push is to get the case treated and patient back to work as quickly as possible. And I think that I'm not seeing that in the same kind of tendency towards pushing things along and getting it done, which it's hard to understand why that's the case, other than to say that you must fall back on the gatekeeper issue as well, and the gatekeeper system designed to prevent wrong surgeries from being done, or prevent inappropriate or unnecessary surgeries being done. So that seems to be the common discussion. So the point that physicians are being second guessed is there again, and then they're assuming that physicians are trying to treat patients that don't need treatment. So I think that the whole system seems to be revolving around not only the sense of financial gain and agenda, but also this basic distrust of the medical professional in the care process.
And possibly of the patient too. I mean, I was injured, but because I couldn't just take time off work and wait for this case or whatever to be done, I'm not going to hang my life up on a hook like that. I went back to work. So it's kind of like, oh, this patient's working? Well, how can they be working and have this kind of level of pain? So I don't know. And then it's, well, I need physical therapy. I'm trying to do conservative treatment and not do surgery because why not? And then, you use up a certain amount of time or sessions or body parts, because that's another thing. They kind of split your body up into these uh, parts that they think make sense, which I don't agree with. And they'll say, okay, well, we're not going to approve more physical therapy for you because it's not working anymore. Okay, so then let me get surgery. Well, we're not going to approve surgery for you unless you do physical therapy. Well, so then what do you want me to do?
Back in the circle.
Yeah. Yeah. And again, you had the opportunity to go back to work because you had a very lenient and forgiving and supportive workplace. And a lot of patients don't. So someone working in construction, for example, and a lot of these manual labor jobs, there is no light duty. I mean,
You just can't, yeah.
there's
I
no.
was questioned. I was questioned by the an HR representative who, I mean, so many companies track when are you on your computer or where are you now? So we have that kind of software. And I was asked, why are you not working 9 to 5? Like, why are you missing these chunks of time on, Wednesday, Monday, Wednesday, and Friday, and then you're working another you're working enough hours, but they're not in what we expect. And having to explain, like, well, I have to go to physical therapy so that I don't not work.
Right. And this is someone in the HR department of your company, or is this someone from
Yeah.
HR?
I had to explain, like, well, I'm going to the doctor's office and the doctors are open during business hours. And so it's it's very hard to, as a patient, to choose between like caring for yourself, where caring for yourself falls under these things. Caring for myself meaning I want my body to feel good.
Right.
Caring for myself meaning I need to get money so that I can get food and
Right.
not be homeless,
Right.
because that would be even worse. Or at least in my point of view, that was my choice. I'm Again, I work full time and still managed to get into a very significant amount of debt, and I'm not an irresponsible person.
So that's an interesting point also, because this process, even from your own company, they were trying to understand how this was all working. And the insurance company is trying to figure out, whether or not you're real or not, whether or not they're going to approve your case and put funds towards paying the hospital and the surgeon and the support staff, et cetera. And you're wondering all this time is, you're being exposed to all these questions, which is very invasive. So not only going through all the pain, you're going through the process of trying to get treated and trying to recover and trying to avoid surgery. And then at the same time, you're being asked these very personal questions, and to open up and expose yourself in a way, that your personal life in a way that you would never have to be asked to do. And
I never expected that my entire medical record, including all of my mental health notes for the last, I mean, I was in therapy since 2012. So the accident happened in, what year is it? 2021. So do that kind of math of, well, I'm not mentally damaged from this car accident. Yes, it was traumatic. Yes, it is continuing to be traumatic because you guys are making it so difficult for me. But I, lucky for me, I'm that overachiever type and also very stubborn. But I know plenty of people who just it's easy, or maybe it's not easy to kind of give up on it, of just like I can't even trust, like that really diminishes trust in
Yeah.
the whole system.
I was actually going to ask one more thing. Basically, what I'm understanding you were talking about was that there's a method of delay and then basically denial for the actual insurance company. And so, does this method of delay and denial cost the patient's health in any way? And that's the question I was going to ask, because from what I'm understanding from this conversation, it does cost the patient's health.
Yeah.
Oh
And
yeah.
it makes it worse. It makes the patients actually deteriorate
Mhm.
faster than if they were just to get the care that they needed. So who is it really benefiting? Is it benefiting the person, or is it benefiting the bottom line? Is what I'm asking.
I did not feel at any point that the health insurance cared about me.
Right. Right. And intrinsic to this discussion is the idea that they distrust the doctor and they also distrust the patient. So they're distrusting, it's unclear who the customer is in that situation. Technically, it's the doctor, but ultimately it's the patient because the patient is the receiver of care and services. But, I say technically it's the doctor because the insurance company pays the doctor. So truthfully, the insurance company sees the doctor as their customer. But, the truth is that even that is messy and not transparent. But the bottom line is they distrust both. So is the distrust just a smokescreen for financial preservation of capital and maximizing profit at the end of the day? So from the perspective of a doctor, it seems that way. It seems that there is that they could do a better job at analyzing the data. For example, if there's a question in your case, and they're relying on a radiologist to provide an accurate depiction of an MRI scan, which I find often isn't as good as I need it to be from a surgical point of view, enough detail, then they could in today's day and age simply ask for the images and have them reviewed internally by a radiologist. And that would, in my mind, that would bypass a lot of issues. Because X-rays don't lie. If the pain is in a certain distribution, they could ask you, "Where's your pain?" and bypass the physician assessment altogether. You say pain down the right arm into my first 3 digits. Okay, fine. That's C5. That's a C5-6 disc, C6, or it's a carpal tunnel related pain. So let's differentiate further. Get an MRI scan, and we'll do an EMG. So EMG is negative. There's no carpal tunnel. There's a C6 radiculopathy. Negative or carpal tunnel. And then they get the actual image. So if they wanted to blame distrust and all of this, they can get past that very quickly and save money by just going to source data and say, oh, this is all true. Fine. I look at the MRI, right? So ultimately, is this something that gets solved by AI, or is this something that's made worse by AI? Ultimately, does AI read the image? Does it read the image? Does it look at the reports and say this patient likely has a cervical disc herniation causing pain, and an ACDF would likely benefit this patient at this time, given the patient has failed conservative management? And it's not a complex decision. You put all that together. If that's the equation, then why are we having so much trouble getting past the noise of the gatekeeper process? And then forcing us to think that it's all greed. It's not really an error in process. Maybe it's just an error in how they're doing it, right? Maybe they've just resorted to, well, we'll get tremendous efficiency by putting everything on the internet, giving everyone lists to run through their lists. At the end of the day, no one's ultimately responsible for anything.
Yeah.
So that's interesting. I never expected to come to this point, but that's an interesting problem because it means that the depersonalization effect that occurs as part of the internet itself, intrinsic to the internet in many ways, is really another problem that is impeding proper analysis and treatment of cases.
And maybe kind of moving that shift away from this, like the humanity aspect of, oh, I see you're suffering, you're not able to work. How is AI going to, and computers and all this stuff, how is it going to be built into this system where people are already worried that bad things will happen? I'm worried. Of course I'm worried. I've seen the movies.
But you know what, Katrina, gets us to an interesting point, because the internet allows for transfer of DICOM images for imaging. For example, I can send an MRI literally in microseconds to anywhere in the world, right? Mm-hmm. And you can do it in a HIPAA compliant manner with right technology. So the idea that it's just a matter of distrusting the doctor kind of goes out the window. Because if they were distrusting the doctor, then they would have panels of radiologists that would they'd ask for the MRI, they'd review the MRI and agree. So then it wouldn't be in your, I would say that these cases are very clear 90% of the time, because either there is a disc herniation or there isn't. There is either nerve root compression or there isn't. And the MRIs are usually incredible quality, CT scans as well. So if you've read the MRI, you would say, well, there is pathology. And if they cared, I hate to put it that way, but if they cared ultimately, it wasn't just a gatekeeping financial issue. They would zero in quickly and say, well, let's look at the MRI scan. That's the next step here. I'll have a radiologist down the hall. We hired radiologists to do this. Let's have them review this and get a second opinion. Or for that matter, why don't we install an AI system that reads MRIs just as well as a doctor, have them give us an initial response. We could always question that and then have a doctor involved in that if with the disagreements. So, I mean, there's a lot of ways to do this, and a lot of money is going into this whole process of gatekeeping. So now you wonder, how many more people could be treated if this whole kind of nebulous process of gatekeeping was replaced by something that actually made sense.
Yeah, I also kind of wonder too if it's like, well, they could do that, but does that mean that we meaning, oh, I'm an insurance company, would have to pay for more of these expensive surgeries?
Right. I don't think so. I think there are X number of expenses of cervical disc herniations that happen per year on average, plus or minus 5%. And that's your expense. And if if you have 100,000 lives that you're caring for as an insurance company, 4% are going to have cervical disc herniations and 2% are going to require surgery. And, or maybe 1% will require surgery. And that's your expense. So that's actuarial analysis. And they have, very sophisticated computers doing that, and good, well-trained, mathematically trained data analysts looking at that as well. And so you would imagine that excuse has kind of disappeared as well. It'd be interesting to know if the denial rate amongst physicians working for Optum was the same as the denial rate for private practice doctors.
There's one other thing. You were bringing up how these companies might integrate AI into their decision-making process. The only issue that I could see coming out of that is bias, right? So it being like, how can I deny this person in any way possible, shape, or form, and make it it's just impossible for you to get the help that you need.
Yep.
And so that's a problem with that software you're talking about.
Yeah, I'm not even sure it's the right place. It's the right move. My point is that if it was really distrust of doctors, then they would ask for the source data to prove the doctor is either not reading correctly or not being truthful or making an error or was correct, right? So 3 possibilities. And so that would solve that question right away. So if it was distrust, logically, that would be the next step. Right? Let me see your source data. And they stop at the radiologist report, even when I write my report, that the radiologist report does not cover the pathology I'm describing or I'm seeing. And so now the radiologist is kind of on the hook, and they're saying, I read the image to the best of my ability. They're a generalist, they're not a neuroradiologist. How many neuroradiologists are there? So now you have this issue where you have this. So I don't think it's a matter, that would suggest it's not a matter of trust, because they're not going to the source data. It seems to be a matter of financial process rather than trust.
Yeah, I think that as long as there's money involved in anything having to do with healthcare, then you're gonna it's already corrupted.
Right.
In some way.
Unless Michael's point, which is that if you have a positive MRI and then you send it to Chat GPT or to Google software, and it comes back and says, yeah, you have a C5-6 disc. Now you've confirmed what the doctor said, which makes perfect sense. It's almost like getting a second opinion. Yeah. And then you get a second opinion. The doctor says, yeah, you have a C5-6 disc. Now there's no question in your mind that you have a C5-6 disc, and that causes your pain. And then you're actually advocating for yourself in the insurance process. And there's a process for doing that where you've personally verified and validated your condition by seeing doctors and getting that input, and that you believe it as well. And now there's a doctor's input. And maybe there's a separate independent AI input that's giving feedback that isn't. The problem is it can always be biased there, and it's true, just in the way the systems are trained. But that could be another input, and I think that then it becomes almost mathematical. I mean, given this information that you've inputted, it shouldn't be a person doing an analysis. I mean, really, once the data is entered and the analysis is complete by a human being, then it's really just algorithmic. Is this something that should be approved or not? And if it's not approved, there should be a very clear set of reasons, not nebulous, like prior medical treatments not fully delineated. Even though we say in the report you've had 2 years of physical therapy, and pain management with epidural steroid injections, etc. They're still writing these denials as if that didn't exist. So, yeah, I think the system is so complex that the complexity obfuscates the reality, and I think some of the obfuscation must be intentional, because it must be.
Yeah, I mean, it just feels like that for sure. It definitely feels like oh, let's kind of, at least for my workers' comp, like, well, let's see. Let's just wait and see, and then maybe they'll give up or die.
So let me ask you, after all of that, are you feeling better? Are you
Yeah.
doing well?
I am feeling better. I'm still, on the mend, but I mean, I just can't believe the difference. Like, I'm not taking pain medicine. I don't want it. I don't want to do that, and I had to for several years, which it's
Right.
just frustrating. Um,
I'm really
so yeah, thank you. I
Terrific.
got this cool scar now on my
Yeah.
neck.